The American Medical Association had 5 things that were the top 5 medical advances of the 20th century, and hip replacement was one of them. Because it took people who were literally sitting on the porch with their cane not moving anymore because their hip hurt so badly, and it gave them back their life entirely. So arthritis is actually a very catch-all term. If you break it down in Greek, arthros means joint, itis means inflammation. So we're talking about joint inflammation. So there's different types of arthritis. Even if you sprained your ankle, it would be technically arthritis. But what we're really talking about when we talk about knee arthritis or hip arthritis is the degenerative condition of the joint due to a variety of factors: aging, injuries, genetics, sometimes just plain old bad luck. And so as the joint deteriorates, it starts to hurt because it gets inflamed. The bone gets inflamed and the lining of the joint gets inflamed. In the hip, it's the ball and the socket. The actual ball starts to wear out, the socket starts to wear out because the cartilage inside the joint will wear away due to those factors we just mentioned. As that happens, patients will notice pain, typically in their groin or the side of their groin, sometimes in their buttock. They'll notice stiffness, difficulty putting on their shoes and socks, lifting their leg out of the car, going up and down stairs. Sometimes they'll have pain at night when they roll over in bed. Sometimes they'll have pain when they walk a long distance. They'll have to stop and move around and wait for the pain to pass. And oftentimes they'll be very, very stiff when they first get up from sitting for a long time, such as in a car or a movie theater. When that happens, oftentimes they think they've got a groin pull. They think, oh, maybe I pulled a muscle, et cetera. So they'll try things like yoga and stretching, and all that may help for a while, but eventually they say, look, this is hurting too much, and they come to see a physician, oftentimes their primary care doctor, who suspects arthritis either on examination or an x-ray, and they'll send them to see me to talk about the specifics of that. When you see me in the clinic, there's basically 3 parts of how we figure out what's going on in the body. There's a story that you're going to tell me. There's the things that are going on, like we just mentioned, the stiffness, the pain, what can I do, what can I not do, what is changing over time. Then there's the examination. We'll have you walk down the hallway, we'll see if you're limping, we'll watch how you're limping. We'll take your hip and gently move it to determine how stiff it is, determine what makes it sore. Look at your leg lengths, because sometimes with arthritis, the leg can shorten because the ball grinds its way up into the socket. And then sometimes we'll do special tests like strength tests, et cetera, if we think it might be something other than your hip, like your back or maybe your knee or something else causing the problem. Finally, the last piece of the puzzle is the imaging. Typically with us, x-rays are very, very valuable. We don't often need MRI scans with arthritis because x-rays can tell us if there's significant narrowing of the joint space. We see the cartilage wear away. We see large bone spurs form. We see other deformity of the ball in the socket. So those 3 things can give us 99% of the information we need to help make a diagnosis. So in medicine, you need to have a diagnosis in order to have a treatment plan. So everyone comes in saying, how can I make this better? The first thing we have to do is figure out, okay, what do you actually have going on here and how bad is it? So with those 3 things we mentioned, the history, the physical examination, and the x-rays, we can tell how badly this problem is mechanically in terms of what I can see. And then what you tell me is how bad it's affecting you physically and psychologically and emotionally and socially. And from that, we craft the treatment plan. Sometimes it's something very simple. Some patients come in and they just want to know what's going on. They say, look, why am I having pain? And once they know, they say, okay, I'm fine. I can live with this, doc. I'll come back and see if it gets a lot worse. Some patients come in misery, the opposite end of the spectrum. And they say, look, we need to do whatever we need to do because I'm at, red level 3 and we have to figure this out soon, doc. It's rare that we suggest surgery right off the bat when someone comes in. Even though we're surgeons and I love doing surgery, I'd say probably 8 out of 10 patients that come in don't get surgery. They have some other type of non-operative treatment that can get them to the point that we always say, look, if this is good enough, then we can go on that trail for as long as it will carry us forward. If it's not good enough anymore, then we go to the next level of involvement. So for example, with hip arthritis, we might try an anti-inflammatory medication. We'll put someone on either a low dose of a over-the-counter anti-inflammatory or a prescription anti-inflammatory to see if we can calm down that inflammation in the joint. And you may not have to be on it for a long time, maybe just a couple of weeks. Sometimes you have to be on it a long time, and if that's the case, we get the primary care team involved to make sure that your kidney function and your blood pressure and your stomach function are all doing okay with that medication. And again, some patients take that medication and that's all they need for either a short period of time or a long period of time. If that doesn't work well enough, We'll also throw in things like physical therapy to try and work on gentle strengthening, gentle stretching of the joint to see if we can increase the mobility and increase the range of motion and the strength. And sometimes that can decrease the symptoms once again to make it just good enough that patients say, I can live this way. If those things aren't working, then we'll oftentimes move to considering a cortisone injection in the joint. Now, cortisone is just a liquid anti-inflammatory medicine, and that's all it is. Think of it like liquid aspirin or liquid ibuprofen. We can put it in the joint in a concentrated form, which we can't do by taking a pill. You take a pill, some goes to your hip, but some goes to your earlobe and your big toe in places you don't need it. So by putting it in the joint in a concentrated form, we can not only isolate where it's working and keep it out of the rest of the body, but we also can have a much more potent and long-term lasting effect of the dosage. A cortisone injection is incredibly variable in terms of how well and how long it works. So some patients, everyone gets some relief. But some patients will have massive relief that lasts for a year or more, which is great. Some patients have some relief which lasts for a week, which is not so great. But the fact that they even get better a little bit for a while tells us that that's the problem. It's not coming from some other location like their back or their knee or somewhere else, because we put the medication in the joint and that's the only place it was. And so therefore, if it was going to work, it had every chance to work. If someone comes back and tells me, that injection didn't help me at all, then I start thinking, okay, what am I missing here? Something's odd. We're barking up the wrong tree. We got to look for a different source of the pain. If the medication works, if the injection works, then it's okay to repeat it, provided you spread things out by at least 4 months or more apart with the injections. Some docs go to 3 months. I kind of like to go to 4. The reason being that cortisone can have damaging effects on the collagen, the connective tissue that builds the joint and the ligaments and the lining of the joint if you do it too close together. They found that out back in the 1920s and 30s. So what we do is we try to inject someone as close together as we need to, as far apart as we can get away with. And so some patients will come in with an injection once a year, every 9 months, every 6 months. Some people start to get closer and closer together as their deterioration continues to worsen in the joint and the joint gets more sore and more problematic. At some point, eventually everyone will get to the point where it's not working well enough anymore. So once again, that well enough bar is no longer being met. At that point, we start talking about surgery. The surgery for hip arthritis has come an incredibly long ways in the last 30 to 40 years. Hip replacement, which is actually putting in a new ball and a new socket into the pelvis and the upper part of the thigh bone, was first pioneered in the 1950s and 1960s in England. And it came to the United States in the 1960s, 1970s, and it became very, very popular because hip arthritis can be incredibly disabling. When we got to the year 2000, and they were making all those lists in the millennia changeover of the greatest things in the last century, the American Medical Association had 5 things that were the top 5 medical advances of the 20th century, and hip replacement was one of them. Because it took people who were literally sitting on the porch with their cane not moving anymore because their hip hurt so badly, and it gave them back their life entirely. So it was an incredibly dramatic change. And the thing that's changed in the last 20 years or so, in the United States especially, is the technique by which we do the surgery. So when I did my training at the Mayo Clinic in the early 1990s, the classic approach being used in the United States at that point, surgically, was to come from the back side of the hip on the side of the buttock. That was called the posterior approach. It was a wonderful approach that had been used throughout the world, and it had some distinct advantages over the original way of doing hip replacement. But the problem with that approach was it cut some tendons and muscles, and there was a fairly high dislocation rate if patients would bend over at the waist too far. They could pop the hip out the back because we had cut through that area. Even though we sewed it back together, the scar tissue wasn't strong enough to keep the hip from popping out in about 3% of patients. So it had a 1 in 30 chance your hip would pop out over the lifetime of the replacement, which wasn't very much fun, of course, for anybody. So in the early O's to teens in the United States, the anterior approach became very popular. This was first seen in France and in Europe, and it was brought over by some surgeons in the United States. And I started doing this in about 2010. And the approach comes from the front of the hip. And that approach thereby does not cut any muscle tissue. We basically spread the muscles aside and we approach the hip in that manner so we don't have the same damage to the tissues around there. So the dislocation rate dropped dramatically. It's now down about 1 in 1,000 from 1 in 30. So that was one wonderful piece of advancement that we had. The second thing that's wonderful about the anterior approach is that we were able to use X-ray control during the surgery to allow us to position the components in a very precise and exact fashion. This has also been done with robotic surgery and computer-guided surgery, but we can do it with X-ray surgery exactly the same, and we find that it's less invasive to use the X-ray machine without using the computer-aided towers that we have to attach to the body in different locations. That allows us to, once again, get that perfect precision placement of the components, which allows, in theory, better function for the patient and better long-term durability of the components, because malposition of components can be something that leads to early wear and tear and failure of the implants. The final thing that's wonderful about the anterior approach is because it's less invasive, patients can recover much more quickly in the early going. If you look at patients 6 months down the road, no matter what approach is done surgically, they all are about the same at that point, provided they haven't had a complication. But with the anterior approach, the early recovery, that first 2 or 3 weeks, is dramatically quicker. Patients are up moving right away. A lot of patients get rid of their walker or their crutches within a couple of days to a week or two, and they're back to work more quickly, they're back to activities more quickly, there's less pain, all of which have been an enormous advancement, and of course, patients love that.